Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to have a discussion that I believe may come across as exceptionally basic, but it is exceptionally important with respect to how you actually perform osteopathic manual medicine, osteopathic manual manipulation, osteopathic manual therapy, depending on the jurisdiction that you're in and the preferred or appropriate term. But in any case, hands-on osteopathic work is highlighted and differentiated by the barrier concept from all other hands-on therapeutic approaches. Very broadly speaking, the way that I tend to explain this is that all hands-on manual practices will be attempting to identify motion restriction, whether it's gross motion restriction or yields to pressure of soft tissues. So either the soft tissue squishes or it doesn't. That is the fundamental thing or the fundamental behavior that you'll be able to observe as an external observer to those professions. They will tell a wide variety of stories, but the actual behavior that they engage in is identifying things that don't move and helping them move. Very, very broadly, what I also say is that most hands-on manual practices do not mind if they make the patient say ouch. They don't go looking for it. They don't go looking to generate a noxious stimuli or a pain response in the patient. But if it happens, they don't mind. Whereas osteopathy has the central feature of the barrier concept, which in essence instructs you to make a choice as to how to move towards or not necessarily towards, but it's either to engage restriction or not engage in restriction is probably the best way to say it without stumbling too much. So the direct barrier is going in the direction of motion where restriction short of the anatomical barrier lives. Whereas going indirect, some may define as going into the direction of ease. However, it is not necessarily that with respect to treatment. With respect to treatment, going indirect is essentially in any given area making the soft tissue soft, while going direct is going in the direction of restriction while not making the patient say ouch. So staying short of ouch. And ouch isn't necessarily a verbal ouch, it's the tissue jumping, it's pulling away, it's very mildly resisting a movement, it's apprehension. So there's a lot of ways in which it can show up. But that is the fundamental characteristic of osteopathy that differentiates it from any other hands-on profession, is the barrier concept. I've talked about this before. When going direct, you're trying to go direct or into the motion of restriction or the direction of restriction without the patient's tissues contracting either reflexively or actively. So reflexively, you could say you've got a muscle spindle mechanism kicking up. You could say other things, or you could say from top down, the person's apprehensive, so they contract to protect themselves because they're concerned or scared, or they're feeling a sensation that they don't like. So you're trying to go direct while not making the soft tissue respond with contraction. Probably the most succinct way to put it. Whereas going indirect, you do whatever set of movements in an area where the patient does say ouch, and you make it all go palpably or identifiably or observably soft. One of the main challenges with any form of healthcare practice is a differentiation between a sign and a symptom. This is exceptionally important for hands-on manual practice. A sign is what anybody can identify, including the patient. A symptom is what only the patient can identify. One of the problems that you run into in hands-on manual practice is that you cannot feel what the patient is feeling. You can get limited proxy information. That limited proxy information is patient report verbally or some form of contractile protective response. So you're trying to learn how to move without engaging those things in osteopathic manual practice. So what you're looking for is to choose a way to move that is going to minimize as many opportunities for the patient to have a need to protect themselves as possible. You're looking for proxy signals. As I noted, those proxy signals are audible, visible pain cues, right? So ouch, like somebody saying something along the lines of ouch, or an abrupt response to an abrupt movement would be a better way to say it. So, ouch, like, making faces, things of that nature. Actively telling the practitioner, hey, that's uncomfortable. Hey, that hurts, like something along those lines. is another audible cue. A visible cue is the facial expression. A visible cue would be something along the lines of the person, you could see them activating because you'd kind of get a jump in whatever you're moving. You'd be able to palpate that because you're touching it. So there's multiple layers of feedback that will let you know that it's uncomfortable for the patient, but they won't always happen when the patient is uncomfortable and protecting themselves. So the fundamental mechanisms that you would talk about with respect to reflexive protection are the muscle spindle. So you move to a length or at a speed that is above a certain threshold and below another threshold, whereby the muscle spindle will make the muscle belly, or the gamma and alpha motor neurons will talk to each other. There's crosstalk. I'm not going to properly explain the mechanism, but the muscle belly will contract to protect itself so it doesn't go beyond a certain length. If you go fast enough, the Golgi tendon organ will shut the muscle down. So those are your reflexive muscle-mediated protective mechanisms. There are a lot of other sensations that can be interpreted by a wide variety of people in a wide variety of ways that will give them the top-down notion that they should protect themselves. So moving at a particular speed or accelerating at a particular level could get the muscle spindle, it could get the Golgi tendon organ, or it could just feel a particular way that somebody interprets as something that should be protected from. So they will essentially do it from the top down. They will do it cognitively and protect themselves. But it may not show up as identifiable resistance to the movement. It may not show up at all to the sensory system of the practitioner. If the practitioner is moving at a certain speed, they're probably not going to sense what happens. This is called blowing past the barrier. You just went at a speed or to a location where you didn't detect it, right? Or some combination of both. You don't want to move too slow because it's creepy. You don't want to move too fast because you could miss stuff. You want to move sort of at an in-between pace, and you can test that for the patient. You can purposely move slow and then see if you can move faster and see how they respond. If there's any kickback, if there's any contraction, you'll be able to visually see that. You'll be able to palpate that or note resistance, and then you can adjust. In your normal movement as a practitioner, you probably already do this. You probably already explore a little bit of call and answer, see what works. But if you think that there's a way to do things, you generate circumduction at this rate, then maybe you'll blow past it too. There are some people in osteopathy that talk about rate, rhythm, and repetition. It's a great concept. When you see it in action, what you would like to see is no identifiable signs that there's resistance to that rate, that rhythm, that repetition, that it's not uncomfortable. So you don't want to see any faces. You don't want to see any guarding, any protection. You're looking to move in a way that gives people no reason to protect themselves from what you're doing, because then you are appropriately utilizing the barrier concept, whether you're going direct or indirect. Again, there's a lot of sensory surfaces in the body that can send information to the brain that could be interpreted as completely normal or something to be protected from. But you won't know it if you move incorrectly. So if you're in a position, I should touch back on this, that you're moving too fast, or you've got high elbows, or your hands are quite twisted, or you're standing in a way that you're reaching a lot, or you're quite tense in any part of your body as the practitioner, then your sensory surfaces are going to be overloaded with sensation from yourself. So you want to be as mechanically sound or in as advantageous a position for good leverage and low work as possible, so that you can, when you move at a particular speed that is appropriate for the patient, that they don't guard or protect, that you can actually sense it instead of sensing your elbow, your bicep, your neck, your foot, your leg, whatever it happens to be. So if you like to work in lateral in front of a patient, then that means you have to push your thighs against the table, reach for whatever you're working on, and because you've straightened your knees and pushed your thighs against the table, you have an eccentric contraction in your hamstring. You have to grip with your feet so that your feet don't slide, regardless of the type of shoes or surface. You're going to do that. You're going to really lock up your legs. Your legs are going to get tired. You're going to pay attention to you more than them, because you choose in lateral recumbent to work in front of the patient. So now you have to reach. Whereas if in lateral recumbent, you generally, as often as is reasonable, work behind the patient. The patient can be better supported on the table. You don't have to reach particularly far because they're close to you. You're over top of them. Even if you need to sit, you can, but they're close. You don't have to reach. So you're getting yourself in more mechanically advantageous positions. This all then plays into proper utilization of the barrier concept in real time, in real life. Because you can't feel what the patient feels, you have to attempt to work in a way that is shy or short of those protective mechanisms, that is very dependent on speed, that is very dependent on force, right? Tension in you versus tension in them. You're trying to essentially not be noticed. If you are learning osteopathy, regardless of background, one of the things that is going to benefit you greatly when you're working with whoever you're working with is attempting to inculcate the concept for communication that the person being worked on should say, I am feeling close to needing to protect myself. I want to tighten up. Because then that can give the person working the opportunity to reflect and say, I moved at this speed. It'll be pretty automatic. They won't think about it much. But they won't think about it consciously much in all likelihood. It's probably going to work more on an implicit level. It's slower, harder to change learning. But you tell them, you're moving in a way that makes me want to protect myself. They may not be sensing any of the information that would be able to tell them as a proxy that you want to protect yourself, but they need that verbal information. So there will be times when a practitioner or a learner is moving somebody and they're moving and they're quite sure that the person could move farther. And realistically, the person can move farther, but it's inappropriate because the person's starting to get apprehensive. So you want to give the learner and the person working the opportunity to gather the information that says, hey, I think they can move farther. I can prove that they can move farther, but I can't detect that they're getting apprehensive. I need to know what it's like as an experience with a wide variety of people, that they're getting apprehensive about what I'm doing. Yes, they can move farther, but they're getting apprehensive. And as a learner, as somebody practicing, you would not know that unless somebody told you. That is something that might improve the learning and practice experience of osteopathic practitioners so as to give the patient, the client, or the fellow student you're practicing with the opportunity to inform you, especially early on in your career, that you're moving in a way that you can't detect is making them want to protect themselves. Again, to sort of sew this together in a different way, this matters because not everybody will present the same type of responses to movement that will make them uncomfortable, apprehensive, have small pain sensations that they will start to resist. Not everybody's going to present it the same, so you need to build up a bank of the wide variety of ways that can appear so that as a practitioner, when any of those show up, you can start to test and figure out whether or not you should speed up, you should slow down, you should increase pressure, you should decrease pressure. You need some way to gather that information when you're learning and when you're practicing so that you can start to know what it's like when somebody isn't showing obvious signs of engaging protective mechanisms. They're showing subtle or no signs that are clear, but you might be able to pick up as a pattern. So things like changes in breathing rate that you won't absolutely be paying attention to, but you can hear them take a deep breath. You can start to notice that they aren't breathing, that they're holding their breath. It's pretty subtle. It's not exceptionally explicit, but you can start to notice those things over time, regardless of how you approach this, or you could explicitly recognize them earlier when you're providing education to people, or you're providing training to people, or you're somebody who's learning. You can say to whoever you're working with, hey, when it gets to a point where you start to feel like you want to protect yourself, I need you to tell me so that I can start to relate what I did to what you tell me. Now, this will also lead to a wide variety of expression because some people will be much more sensitive to feeling like they need to protect themselves for a wide variety of reasons. You don't absolutely need to explore that. You need to acknowledge that that's real and build that bank. So person A may be almost numb. You can do almost anything to them and they won't kick back, they won't protect themselves. Person B will be completely fine except for one or two types of things that you do. Maybe in seated, they're very apprehensive for some previous reason. They interpret any work in seated as uncomfortable or requiring them to protect themselves. Maybe person C is okay in seated, but anytime you put them in prone because they feel like they can't see what's happening, they get very concerned and they get very apprehensive. They will give off some set of signals. Now, you span that across, or you build that across a large amount of people, giving you these proxy signals for feeling like they need to protect themselves. You build up a bank, so you start to notice that information explicitly so that you can get to the explicit understanding earlier of when you probably should adjust to properly respond to the barrier concept, which I put forth as the heuristic of don't make them say ouch. So don't move at a speed that means they need to protect themselves. So too fast or too slow, you got to find that right speed. Don't move at a force that makes them, or apply force quickly or with, there's a weird, I'm trying to say force at a certain level of force, but that's not appropriate. So let's just say a certain amount of pounds per square inch, right? So applying force at a certain PSI that's going to overwhelm them. If you move at a relatively neutral pace with a hand that's not pawing around and searching too much, if your search pattern's like this, so kind of apply, pull out, not pull out, apply, remove hand, replace hand in new position, apply, as opposed to apply, move, apply, move. It's a short sampling for you. It's a short sampling for the patient. It feels like you don't know where you're going. It feels like you're searching randomly. If it's a more purposeful search, a more sort of smooth medium pace, you don't apply force quickly. You build force slowly to figure out where they start to protect themselves and you can back off. Or you can start to feel resistance early and hang out there and apply more force over time. You'll avoid the protective mechanisms. You'll allow for habituation. You'll allow for them to be comfortable cognitively and reflexively. The barrier concept contains all of this if you apply it right. It's very hard to learn to apply it right if you, as the practitioner or the learner, are working on somebody else and you do it your way. You're never trying to do it your way. You're trying to do it the patient's way. This requires attentiveness. This requires attention to what's going on between you and the patient. So you are applying some form of movement and they are responding. Then you have to respond to them. If you don't respond to them, you're bullying them. You're applying your ideology to them. You're not properly paying attention. So the patient experience is very important. Appropriate care is always patient-centered, but it is often practitioner-initiated as far as the actual intervention. The patient presents with an issue. The practitioner will assess what they're able to find within their framework. Then they have to make a choice how to begin to intervene. When they begin to intervene or interface, the patient will respond. You have to pay attention to that. Otherwise, it's inappropriate care. It's ideological. It's inappropriate. So, as much as this seems like a long ramble, there's a lot of stuff that goes into proper application of the barrier concept. In order to better grasp it, get a better handle on it, really figure out that you're figuring out the person in front of you, empower them as your partner, whether you're actually treating them or you're learning as a student. Empower them with the opportunity to tell you, hey, I feel like I'm going to have to start to tighten up to protect myself. Because then they can back off a little bit and then they can ask you more questions and say, look for more signals, more proxy signals for how your tissue is responding, for what that's like for you and their ability to interpret that, and then compare that against their bank of previously learned information so they can properly apply the barrier concept. As much as it's a simple thing to say, just don't make them say ouch. To actually do it, you need to build the understanding of what it's like before they say ouch. Right? So sometimes you have to get them to the point where they want to protect themselves, or they do jump, or you do put too much tension into the tissue that they have to respond, or you do move too fast. You have to explore that space, so you have to miss a lot in order to be able to accurately interface with them so that you stay short of it, and then you can learn how to modify that. I would predict that it is easier for you to do earlier in your learning career or your practice career if you empower people to tell you that you're getting close to them wanting to protect themselves. Often you can start that within your intake process, and you can say something like, hey, if anything's bothering you, tell me. If you jump, I'll immediately back off. Like, I'll immediately remove pressure. If you start to pull away, I'll remove pressure as fast as I can. But if it's happening and you feel it coming, tell me. It's something that I do in practice. I do tell people, if you feel like you're about to want to pull away from what I'm doing, tell me. So as much as I'm explicitly saying this, I've implicitly built it into my practice over time, where I tell people to tell me before it gives them trouble. Now, in the position of an educator, trying to influence learners, educators, and practitioners to improve their ability to tune into the person that they're working on, and hoping to intervene with or interface with in a way that's helpful to both of you, have that conversation in some level that's acceptable to both of you, to say, hey, just let me know. If you think it's going to get close to giving you trouble, tell me. And then I can back off on your behalf, right? It is a conversation both cognitively, verbally, and with respect to visual stimuli and palpatory stimuli for resistance to movement. These all come together in a very multisensory way, such that you can build your understanding so that on any one of those senses or any one of those pieces of information, you may be able to figure some of it out. And when they all come together better in your experience bank, you figure it out better with less, sometimes with all the information, sometimes with less information. But if you don't have that, you're not moving towards that expert level from the novice level, such that you can identify when you're being appropriate as far as your speed, your force, how the patient's responding, and how to figure that out. One of the easiest ways to figure that out is to tell somebody who you're working on, whether you're a professional or a learner, tell me when you start to feel like you want to pull away so I can back off. Whether you're trying to go direct or indirect with respect to the barrier concept. But the actual application of the barrier concept involves all of that. It's all important. It all matters. But to have this discussion that maybe some initially will find mundane, you can listen to me for 20 some odd minutes, give you insight into how to leverage this to best improve your skill set, best improve your ability to attend to the individual in front of you, and best improve your outcomes. Because if you stay short of the patient saying ouch by using the barrier concept properly, then that is likely one of the more useful ways to apply the term osteopathy to a patient encounter or to a client encounter, because you're attending properly to the fundamental difference between osteopathy and all other hands-on manual professions. It's not that professionals and other, or practitioners in other hands-on professions will purposely look to make the patient say ouch. They just don't mind it. Whereas in osteopathy, you will find practitioners who will not care if they make the patient say ouch. But as a professional group, as a profession, osteopathy has that highlighted, has the barrier concept. So I'm only suggesting that you apply it properly if you're going to work osteopathically, quote unquote. So barrier concept, while I can say something as simple as don't make the patient say ouch. If you want to go direct, you go in the direction of resistance without making their tissue contract. If they say ouch, then you go and you make the soft tissue soft with whatever combination of movements you need. But then there's all the other stuff that I said. So hopefully this gives you more insight into the application of the barrier concept, as well as how to empower whoever you're learning with or you're practicing on to help you sense things that you can't sense. So the sign is the movement problem, the resistance to the movement. The symptom is the sensation the patient has. Empower them to provide you with information about the symptom you wouldn't otherwise have or be privy to by telling you. So hopefully that was useful, and we'll talk again soon.